we have here. We're very excited to have our first speaker, Dr. Adrienne Campbell-Washburn from the National Institutes of Health. She's a Earl Stadman investigator there, and she's the leader of the Laboratory for Imaging Technology, which is in the NIH Clinical Center, the intramural branch of the National Heart, Lung, and Blood Institute. Her and her team are really pioneers of what can be possible, what can be done when you pair contemporary design, high performance gradients with a lower field strength. And so thank you, Adrienne, for joining us today. Take a few seconds to connect.
Thanks for having me. Can you hear and see me? Oh, I got some yeses in the chat. All right, I'm glad. Okay, I'm going to try and share my screen. Hopefully you can see my desktop. Ooh. Krishna, can you just give me a thumbs up if everything looks good on your end?
Yes, it looks good over here. Thank you.
All right, I will get started then. Well, thank you so much for inviting me to speak. I presented at this workshop in 2019 when our high performance low field system was still relatively new. So today I'll give you a bit of an update on what we've been doing since, specifically on the imaging we've been doing in the heart and lung. And so I wanted to start just by outlining what we mean when we say a high performance low field MRI system. And so this is a system operating at a lower than clinical field strength, specifically 0.55 Tesla, but it pairs along with that lower field system, contemporary hardware and advanced imaging methods. So in contrast to older generations of 0.5 Tesla systems, this system has a lot of advanced technology, both in terms of hardware and software capabilities. And the way we achieved that was to take a clinical 1.5T system, which was state of the art at the time. It was a Siemens era system in late 2017, and we ramped it down from 1.5T to 0.55 Tesla. And we did that in collaboration with Siemens. And so starting in early 2018, we started imaging patients, and we've been working on the system ever since. So today I will specifically talk about our work doing cardiac imaging. And then second, I'll talk about our work doing pulmonary imaging. And for each, I'll talk about why we're interested in low field for these applications. I'll talk about some of our technical developments and our clinical validation studies, which are ongoing. So let's start by talking about cardiac imaging. Cardiac imaging is, of course, a very powerful technique for imaging anatomy and function and physiology and giving us exquisite image quality with lots of different contrasts in a single exam. And it's a very powerful technique, but it's underutilized clinically, particularly in North America, because of the cost and the complexity of imaging. And so our hope is that by moving from 1.5T, which is the current clinical standard, down to 0.55T, we could increase the accessibility of cardiac imaging. So if we look at this figure, which comes from one of Larry Wald's papers on the cost of an MRI system, and we think about going from 1.5T down to 0.55T, the biggest part of this pie chart is the magnet and the cryostat. And so by moving to a lower field strength, we have an inherently lower cost to this system. And that's where that 1 million per Tesla figure generally comes from. We also have potential to reduce cost by lowering the cost of the RF amplifiers and also lowering the cost of the sighting. So it can be a lighter system, it needs less shielding, and it needs less helium. We may have a slight increase in the cost of computers because a lot of our modern imaging technology that we use to recover SNR relies on computational power, things like advanced reconstruction techniques. And so we might have a potential increased cost there. And right now we're assuming that we're keeping our gradient system the same. And so we're using a ramp down system, and we've maintained the high performance gradient system. And so right now our assumption is that the gradient system will be cost neutral, but overall we expect that the cost of the system will be lower. It's hard to predict the exact cost because we still rely on high performance elements of the hardware, but we expect that it will be lower. And of course, when we go to lower field strengths, we need to deal with lower SNR, and we have a lot of tools in our toolbox. And so if we look at just the physical properties of the system, the T2 star and the T2 are longer, meaning we can do more SNR efficient sampling. Things like spiral and EPI and rosette trajectories work really well at lower field strengths. T1 is shorter, meaning we can use shorter TRs and higher flip angles if we're interested in doing fast imaging for cardiac applications. We have reduced RF power limitations, meaning we can use high flip angles and new pulse designs without worrying about SAR limitations on the system. And our B0 and B1 fields are very uniform, which allows us a lot of flexibility, for example, using long TRs and long readouts without worrying about image artifacts. And of course, in addition to those physical properties of the system, we also have a lot of modern technology. So we have advanced image reconstruction methods and AI methods, which are widely available to help us improve image quality. And so when we put all this together, we can do a really good job of imaging at the lower field strength. And so to give you a sense of image quality, here are example images from our 0.55T system for a cardiac exam. Here I'm showing cine, flow, tissue characterization, scar imaging, fat water separation, perfusion, and 3D angiography. And we've optimized and validated some of these techniques, although we're still working on optimizing and validating some of the others. But overall, I think our image quality, just to start with, is pretty good. It's almost equivalent to a 1.5T system. So I want to talk about some of the validation studies that we've done. We started with cine imaging because, of course, that's our workhorse sequence that we run in every single patient. And so we took our 1.5T protocol and we optimized it for lower field strength. And there's no magic here. We really just changed the receiver bandwidth and the flip angle and made some other small tweaks to improve our image quality. Our goal was to keep the breath hold length consistent and the spatial temporal resolution the same as 1.5T. We didn't want to give up anything in terms of our resolution or force the patients to have a longer breath hold. So that was really important in our sequence optimization. And so you can see that changing those parameters, we get improved SNR, which is what we'd expect. And as a test, we ran these same sets of parameters on 1.5T, which I'm showing for comparison's sake here. And so if you look at the optimized 0.55T parameter set, what you see is that the long TR causes artifacts at 1.5T, and that we weren't actually able to achieve a high flip angle or as high a flip angle at 1.5T just due to the SAR limitations of the system. And so for our validation study, we wanted to compare best to best. We didn't want to compare a degraded protocol on either side. So we're comparing our 1.5T clinical parameters to our optimized parameters at the lower field strength. And so here are a couple of examples. Here is a breath held cine acquisition in a patient, and you can see in multiple short axis slices, and you can see that the images at 0.55T on the top are a little bit noisier than the 1.5T, but overall they're giving us the same information content. And if we look at the long axis view, we see the same thing. It's a little bit noisier, but the information content is the same. Specifically, we can look at things like fat in the myocardium, which is visible at both field strengths. If we look at the AV groove, we can see fat water banding at 1.5T, which disappears at the lower field strength. And in this particular patient, they had a small focal nodule and thickening of the aortic valve, which again, we can detect at both field strengths. So we're getting the same diagnostic information out of the two systems. And here's another patient who had a wall motion abnormality. And again, if we look at images from the two field strengths, we can see that wall motion abnormality on both field strengths. And we can also see that this patient had a bioprosthetic valve, and we can see the difference in the artifact between the two field strengths. So we thought that that was a pretty good place to start with the breath held cine. But in order to further improve our SNR, we started to move toward a compressed sensing reconstruction. And so here I'm showing a comparison of 0.55T on the left and 1.5T on the right of a free breathing rebind cine acquisition with an L1 spirit reconstruction. And so here I think we're getting to the point where the comparison in image quality is really remarkable. We're getting almost identical image quality between the two field strengths thanks to that compressed sensing reconstruction. And if we look at the long axis view, we see the same thing. So in both cases, we see a little bit of noise in a couple of frames, but the noise is really equivalent between 0.55T and 1.5T. So we've done a really good job of cleaning up any residual noise using this reconstruction. And so in our validation study, we had 60 subjects, 44 of whom were patients recruited for clinical CMR. We performed CMR at both field strengths using a combination of the breath held and the free breathing exam. And our quantitative comparison showed that the LV and the RV measurements, both the volume and the mass, were highly reproducible between the two field strengths. And in particular, if we looked at regional wall abnormalities, we saw the same diagnosis of regional wall abnormalities at both field strengths. And if we did a sector-wise comparison, they correlated really closely. So overall, we are really happy and confident that we can do cine imaging well at the lower field strength. The next technique that we investigated was late gadolinium enhancement. Here I'm showing a 1.5T example using a spoiled gradient echo acquisition, which is the most common late gadolinium enhancement sequence. At lower field strength, we moved to an SSFP acquisition. We increased our flip angle, we changed our TR. Again, no magic here, but you can see that overall the image quality is really similar between the two field strengths. And so by combining late gadolinium enhancement and cine imaging, we can image most patients with coronary artery disease and myocardial infarction and get sort of the bread and butter of our exam, which is a good place to be. And here are some more comparisons at the two field strengths. So at the top, I have the 0.55T images, and on the bottom, I have the 1.5T images. And so in this patient, you can see a large wraparound LAD myocardial infarction. And you can see the yellow arrow showing the bioprosthetic valve. And then in this next patient, they had a right coronary artery distribution subendocardial MI. And again, you can see that MI being visible on both the field strengths. One thing we notice is that because of the change in T1 at 0.55T, the blood in these images tends to be a little bit grayer, which is actually a good thing because it allows us to have more contrast between the blood and those subendocardial infarcts. So that was a serendipitous advantage of the lower field strength. And I'm not going to spend any time on the slide other than to say that if we do a quantitative comparison of MI mass and volume, they correlate very well between field strengths. Finally, we've also done a small study comparing T1 mapping pre and post gadolinium in some patients, in 27 patients with different pathologies. And so as expected, T1 is shorter at the lower field strength. It's about 70% of the 1.5T T1 pre-GAD and about 85% post-GAD. And in these patients, we also calculated extracellular volume. And so in some of our patients, they had elevated extracellular volume, which is of course an interesting clinical feature. We saw a little bit of dispersion between the two field strengths here. And so that's something we're still looking into. But we're starting to build up all of the techniques that we would use for a clinical CMR exam. There are also some other inherent benefits of lower field strength for cardiac MR. So here I'm showing on the top the 0.55T again, and on the bottom the 1.5T in patients who have implants. And so you can see the reduced artifact size just qualitatively for things like sternal wires and valves and occluders, which many of our patients who are undergoing cardiac MRI will have. And in patients with active devices like pacemaker and defibrillators, again, you can see reduced artifacts where artifacts are no longer obscuring the heart. And so this is really promising. It's just qualitative at this point, but we think that this is an interesting advantage of lower field strength. In addition, at lower field strength, we have improved ECG quality and reduced acoustic noise, which again, just improves patient safety and comfort and makes this an attractive environment for cardiac MR. In parallel to these validation studies, we've also been focused a lot on developing spiral imaging for 0.55T. We consider spiral imaging to be an important part of the puzzle to get 0.55T to be clinically adopted for cardiac MR. Spiral imaging is very SNR efficient and it works remarkably well at lower field strengths. And so if we pair that with our advanced reconstruction techniques, we think we can improve image quality a lot. And so this is just showing an ECG gated spiral SSFP cine. At lower field strength, we used a long TR and a long readout, much longer than we can achieve at 1.5T in order to generate high quality images. And we did some quantitative SNR comparison compared to the same patients imaged at 1.5T using our optimized Cartesian imaging acquisition. And of course, when we go to lower field strength, we get about 37 or 38% of the SNR, which is exactly where we expect to be. But as we move to spiral imaging, we can improve our SNR substantially up to about 70% of what we achieved at 1.5T for the identical scan time and spatial resolution and temporal resolution. So our ongoing work is to leverage spiral imaging for other CMR contrasts. As I said, I think we think it's going to be an important piece of the puzzle for clinical cardiac MR at this field strength. So next I wanted to talk about our work doing MRI of the lung. And lung MRI has been very difficult in the past at 1.5T and 3T because of course the lung is full of air tissue interfaces leading to a lot of susceptibility gradients and very short T2 star, which makes imaging very challenging. And so by going to a lower field strength, we're using the same superconducting magnet, but operating at a lower field strength, which means that our B0 field homogeneity has improved linearly and therefore reduced our susceptibility gradients in the lung. And so I like to show these images of patients with LAM because you can really see the comparison with CT, where at 1.5T MRI, we have a lot of distortion in the lungs and can't see the lung parenchyma very clearly. And then by comparison, if we put the same patient in the 0.55T scanner, we see the lung parenchyma with a lot of signal in it, and we can see that cystic pathology really nicely. A lot of our structural imaging so far has been based on T2 weighting, and T2 weighting has been historically difficult to achieve in the lung, but we're using a T2 weighted turbospin echo sequence with a relatively long TR. And here are some more examples of patients with different pathology as well as a healthy volunteer, just to give you a sense of how we can see the lung parenchyma and that pathology. We've also been using this sequence to image patients with COVID-19 infection, where we can see the infiltrates in the lung and the ground glass opacities in the lung really well compared to CT, which is helpful if we're following up these patients for a long time. And to get a sense of how well our T2 weighted sequence was performing, we did a small comparison study in 18 patients with known lung pathology who had already had a clinical CT image. And we imaged them at 0.55T and then had radiologists read both the CT and the MR blindly. And what we found was that for large features like cavitation and consolidation and nodularity, the radiologists came up with the identical result between MRI and CT. But for some of the smaller pathologies like ground glass opacities and tree and bud nodularity, the correlation was only moderate. And so that could be due to the reduced resolution using our MRI scan, or it could be due to the fact that we're imaging at expiration instead of inspiration. So that's something to work on moving forward. But we were encouraged when you look at the comparison between the MRI images and the CT images, how remarkably similar they were in terms of information content. We next moved on to a ultra short TE acquisition. And so here I'm showing a stack of spirals, ultra short TE acquisition with 1.75 millimeter isotropic resolution. And this is a self-gated scan where we use 40% of the binning of the data bin to a stable respiratory phase in order to generate a single respiratory phase image. This is an 8-minute acquisition with a 4-minute inline imagery construction that's implemented on GPUs to be computationally efficient. And you can see that overall we're getting very nice image quality and much higher resolution than we were with our T2 weighted images. So it's encouraging that this may give us something more in terms of imaging lung structure. An important aspect to this work was compensating for concomitant fields. And so a lot of the work we've done over the past couple of years has been coming up with techniques to compensate for concomitant fields. And some of that work has actually been in collaboration with Krishna's group. But concomitant fields are a nuisance field that's generated every time we turn on the gradients. And you can see that they create this 3D phase distribution, which can cause blurring and signal shading in our images. And that exact phase distribution depends on our gradient waveforms. But they're inversely proportional to field strength. They get worse at higher gradient amplitudes, and they get worse at further away from isocenter. So when we're doing lung imaging with a large field of view on a low field system with high performance gradients, we're really creating the perfect storm for concomitant fields. And so here's a comparison of images before concomitant field correction and after. And you can see that the vessels become much sharper after we correct for the blurring caused by concomitant fields. So this is really important to keep in mind at lower field strengths. Our newest development has been an iterative concomitant field and motion corrected reconstruction, which was inspired by the IMOCO framework that was developed by UCSF and team. And so in this implementation, we generate these respiratory resolved images. We then perform image registration, and we put both the concomitant field correction and the motion fields into a single cost function that is, so we basically include all of the information into a single reconstruction problem to generate a higher quality image. And this just gives you a sense of the image quality that we're able to achieve. So on the top are examples with our previous CG Sense reconstruction. And on the bottom is this ICO-MoCo, we're calling it reconstruction. And so the SNR is about double when we use that ICO-MoCo reconstruction. We're basically using the same acquisition, but instead of using just 40% of our data, we're using all of our data and using motion correction to generate a single high quality image. And we've implemented this on our computationally efficient GPU reconstruction system. And so we can generate these reconstructions in line in less than 15 minutes, depending on the amount of data that we've acquired. So it makes it really clinically useful. And you can see that if we don't include the concomitant field correction on the left, we get a lot of blurring in our images in both the vessels and the cysts, which can be corrected using the concomitant field correction. So again, that's really important to include. We've also started to leverage the low field system for lung nodule imaging. MRI offers radiation-free structural imaging and tissue characterization, and therefore it can offer some advantages over CT. And so we've been doing a comparison of T2-weighted F-blade, that structural imaging sequence, and diffusion-weighted imaging in patients with lung nodules, both malignant and benign. And we're finding a good correlation between CT and MRI, and learning that clinically relevant nodules, meaning greater than 5 millimeters, can be imaged and characterized at lower field, which is very exciting. Of course, the main advantage of MRI over CT is the ability to image function. And so in order to image function, we focused a lot on oxygen enhanced imaging. And the reason that we choose that is because oxygen has increased relaxivity at lower field strength, making it a really interesting contrast agent. And so in oxygen enhanced imaging, we image people when they're inhaling room air and inhaling 100% oxygen. We then look at the signal enhancement to get these oxygen enhancement maps that tell us about regional lung function. And we've done a study in a large patient cohort of patients with LAM, comparing healthy volunteers where those oxygen enhancement maps are relatively uniform to patients where you can see these regions of low enhancement related to low lung function. And we found that there was a modest correlation with functional obstructional classification, but we think that there's actually more to this because correlating to a global measurement, it doesn't tell the whole story. With MRI, we can see these regional lung functional deficits. And the most recent lung imaging application that we've been working on is quantifying lung water. And of course, pulmonary edema is a cause of breathlessness, which is a characteristic symptom of congestive heart failure. And with MRI, we can quantify lung water. And so as a precursor to dynamic imaging of lung water, we've been looking at the redistribution of lung water with repositioning the patient. And so you can see in supine and prone, we're able to quantify a redistribution of lung water. And so when you put all this together, you can see that we're making good progress in generating a really comprehensive lung imaging exam that includes imaging structure, function, dynamics, characterizing tissue, characterizing lung water. And that will put us in a really powerful position to image these patients in a way that pulmonologists and radiologists haven't been able to with CT. And so in the last slide, I just wanted to talk about what we're excited about for the future, which is actually combining all of this into a single exam. So we're excited about the idea of doing a full cardiopulmonary evaluation. So we can image the heart, and pretty much as well as 1.5T, we can generate new contrasts in the lung that can tell us something about the pulmonary structure and physiology. We can also pair this with hemodynamic catheterization, which is something I haven't talked about, where we navigate catheters and do invasive pressure measurements in the MRI scanner. And we can pair this with exercise testing. And when we put all this together, we have a really powerful platform to study the entire cardiopulmonary system. So that's something we're excited about in the future. So with that, I will thank the folks in my lab, as well as the team at the NIH, particularly Bob Balaban, who's been really supportive of this project. And I also want to thank our collaborators at Siemens and our collaborators outside the NIH who have helped us to work on 0.55T imaging.